Good evening, everybody. It is a pleasure to invite Dr. Shilpa to this Saga Teaching Forum. Uh, for Dr. Shilpa's benefit, because it's the first time she's participating in this forum, we have an active teaching program. We have at least 4 classes every week for our DNB students. We have 2 students every year, and totally, we have 5 at the present because one of the students didn't turn up last year, I think. And one of these 4 classes is presently from the National Surgical Body. So we have at least 3 from this Sagar fraternity, and we always have one guest lecture from some distinguished specialist in usually something other than general surgery. It could be a gynecology as it is today. It could be a medical oncologist or a radiotherapist or even a basic science microbiologist and things like that. Our students are very keen to learn from every source, every possible source. And for the benefit of this audience, Dr. Shilpa is a very popular and a very academically oriented obstetrician and gynecologist from South Bangalore. She takes active part in many teaching sessions and has taken a leadership role in the Bangalore group of obstetricians and gynecologists. It is indeed a pleasure and a privilege to have her talk to us on a topic which is very important for general surgeons. Endometriosis is pretty common, and it can give symptoms which can overlap with things that general surgeons come across. And so it is important for us to learn about it, particularly the details of the disease and the nuances of recent advances in treating this enigmatic disease. It can present in many ways and give many symptoms and can affect many systems, even though the origin is the uterus, the endometrium. Over to you, Dr. Shilpa, and thank you again for giving us this privilege. Thank you.
Thank you, sir. So I hope everybody can see my screen.
Yes, we can. And
shall I go ahead, sir?
Please go ahead. Yeah.
Hi, today, so I will be covering 2 topics, endometriosis and pelvic inflammatory disease. And what experience practically I have gained over the past 18 years in my practice, and why a surgeon should know about these 2 diseases. What's the role of a surgeon when you have been called by a gynec colleague or your gynec spouse. So what you should know about it to improve the patient care and to improve the management. So endometriosis is the presence of endometrial tissue outside the uterus, which induces chronic inflammatory reaction. It affects the general physical, mental, and social well-being of a patient. So it's one of the most debilitating disease in a woman. And I think of late we are seeing quite high incidence of endometriosis for various reasons. So the presence of endometrial tissue outside the uterine cavity, it's a progressive debilitating disease. It affects nearly 7 to 10% of women in reproductive age group. The most frequent site of implantation are pelvic viscera, uterosacral ligaments, and peritoneum. The less commonly, cervix, hernial sacs, the umbilicus, or episiotomy scars may be involved. Sometimes even lungs is involved. So as you can see here, the commonest being the ovary, where the incidence is about 44%. It presents as chocolate cyst. And the next common being the POD, that is pouch of Douglas, along with the uterosacral ligament. So even the broad ligament is affected. The uterus is affected in a condition called it leads to a condition called adenomyosis and adenomyoma, which is again a very, very symptomatic disease. So again, the sites coming to pelvic, extrapelvic sites, ovary, cul-de-sac, uterosacrals, posterior surface of the uterus, posterior broad ligament, rectovaginal septum, tubes and round ligaments. So here is where the surgeon's role is very important when it affects the posterior surface of the uterus and it gets adherent to the intestines. Posterior broad ligament, where it can cause ureteric involvement, wherein we will require the surgeon's role. Rectovaginal septum, again, there will be a rectal nodule. Tubes and round ligaments, yes, I mean, a general gynecologist can deal with it. When it happens in the intestine, like rectosigmoid or cecum or terminal ileum, proximal colon and appendix, again, the surgeon has to make a diagnosis, because sometimes they just come with pain abdomen, and the patient can come with bleeding per rectum during her periods, wherein a colonoscopy may be required to be done by the surgeon. So it is also seen in lungs and thorax. It is seen in urinary tract commonly, where the woman complains of hematuria during her periods. The lesser common sites is cervix, hernial sacs, umbilicus. Yes, I mean, umbilicus we have seen when we have done the endometriotic clearance. They come back with a recurrence wherein we have seen there is a umbilical involvement. The laparotomy or episiotomy site, tubal stumps after sterilization, and the rarest being extremities. So endometriosis is considered to be an enigmatic disease because of lack of specific symptoms, poorly understood pathogenesis, and limited effective therapeutic options. The last 3 decades have witnessed a significant volume in the research related to endometriosis. The incidence is increasing because of changing lifestyle, increased awareness, and also because of the better diagnostic modalities. So these are typical endometriotic lesions, which look like those red spots this is in the posterior wall of the uterus. So early red lesions are superficial lesions. They can look like a powder burn or a gunshot lesion. They can also appear as white plaques, and it can lead to adhesions, which can be either flimsy, vascular, or dense. It could be a deeply infiltrating endometriosis, which is more than 5 millimeter in depth. So in the ovaries, so they may present with superficial lesions, just like these powder burn lesions, or it could be a subovarian adhesions, wherein the ovary will be stuck to the posterior wall of the uterus, and it will become inaccessible from the vaginal route, wherein it will go sit on the top of the uterus sometimes. If the ovary is deeply involved, then it can lead to a endometrioma, which is also called as chocolate cyst. So chocolate cyst is nothing but a menstrual blood which is just collecting inside the ovary. And this is very important because when a woman comes with severe pain and pain during intercourse, pain while defecating, then this is one of the differential diagnoses that you will have to think of. So here you can see there is a superficial lesion on the ovary. There is a superficial lesion on the peritoneum, and you can see the puckering on the peritoneum. So these are white lesions or again the early red lesions. So these are various theories which are not very important for us to go through. And this is the classification where endometriosis can be divided into peritoneal endometriosis, ovarian, cul-de-sac obliteration, and where there are adhesions between the ovary tube, and we can grade them. So ASRM, that is American Society for Reproductive Medicine, has revised the classification of endometriosis. So it could be either mild, moderate, or severe, depending on whether it is peritoneal involvement, ovarian involvement, whether it is unilateral ovarian involvement, bilateral ovarian involvement, and whether there is obliteration of the pouch of Douglas. So usual clinical presentation is with severe dysmenorrhea, deep dyspareunia, chronic pelvic pain, ovulation pain, perimenstrual pain or bleeding, infertility, chronic fatigue, and pain during defecation. So one of the classical picture that the woman will come with is that she will have dysmenorrhea. Usually the pain will start 1 to 2 days before her periods will start, and the pain is quite intense on day 1 and day 2 of the periods, and then slowly the pain will subside. So it begins like this, and over a period of time, the pain can last up to like 6 days or 7 days, and there can be only about 15 days of pain-free days. And again, the whole symptom of this pain thing again will start to the woman. So this will definitely affect her quality of life. So when any girl or any adolescent, or even when a woman comes with the pain during her periods, then it is very prudent to ask how much of her quality of life is affected with her pain. Is she missing out on school? Does she have to take off from work? Does she have, how many painkillers does she need? And how many injections she might need, and whether it is a progressive thing or whether there were pain-free cycles in between. So all these things are very important when we are evaluating for the pain. So dysmenorrhea often starts after years of pain-free menses, and it may start before the onset of periods, and it continues throughout the menses. The pain is because of the local peritoneal inflammation, deep infiltration, which is close to the nerve fibers. And the pain also is because of the adhesion formation and fibrotic thickening, collection of shed menstrual blood in implants resulting in painful traction with physiological movements. So again, this endometriosis is one of the major reasons for infertility. So the possible mechanisms could be altered tubo-ovarian relationship, altered tubal motility, impaired oocyte pickup from the fimbria, which are all mechanical causes. There could be alteration in the peritoneal fluid, alteration of systemic immune response. Also, it affects the hormones, because what we say is when there is chocolate cyst, so this cyst will keep growing. At least we expect the cyst to grow at a pace of around 1 to 2 centimeters per year, because every period that the woman bleeds, there will be more and more collection inside the cyst in the ovary. And this will start eating up all the healthy follicles in from the ovarian cortex, and her ovarian reserve will start coming down. So this causes defective folliculogenesis also. It causes luteinized unruptured follicle, luteal phase deficiency, hyperprolactinemia, fertilization and implantation failure, and the fecundity rate is lowered. So how do we diagnose it? Here, when we do an internal check, like when we do a per vaginal examination, we usually feel that there is tenderness, and there is a fixed retroverted uterus, tender uterosacral ligaments, or enlarged ovary, which may suggest endometriomas. So deeply infiltrating nodules on uterosacral ligaments or pouch of Douglas, or visible lesions on the vagina or cervix can give more certainty. But vaginal lesions are very rare, but we have seen in about 10% of cases. And the detection is improved if we examine during menstruation, but the pain intensity will be quite high during the menstruation. And rectovaginal examination is required if we are suspecting a deep infiltrating endometriosis. So the gold standard to diagnose endometriosis is laparoscopy. So other modalities may be there, like transvaginal ultrasonography or even a blood test, but laparoscopy is the gold standard. The early red lesions, the white lesions, the adhesions, none of them can be picked up 100% by any other modality. So is histological confirmation necessary? Positive histology confirms the diagnosis of endometriosis, but negative histology doesn't rule it out. Visual inspection is usually histological confirmation of at least one lesion is ideal. In case if there is an ovarian endometrioma more than 3 centimeters and in deeply infiltrating disease, histology should be obtained to identify endometriosis and to exclude rare instances of malignancy. So what about non-invasive methods like transvaginal ultrasonography? See, transvaginal sonography is useful tool both to make and exclude the diagnosis of ovarian endometrioma. So this is more useful in ovarian endometriomas and not in peritoneal endometriosis. And the transvaginal scan will help in diagnosing bladder endometriosis and rectal nodules. The specificity is almost 98% for endometrioma, but the sensitivity is only about 83%. So here you can see a homogeneous hypoechoic mass with low level internal echoes with hyperechoic foci within the wall. So this is a very classical picture of endometrioma. It could be unilocular, multilocular with thin or thick septa. So the other differential diagnosis on the scan could be dermoid cyst, but in dermoid cyst, there will be acoustic shadowing because of the presence of calcium. And it will be an echogenic lesion. It could be a hemorrhagic cyst. It has high level of internal echoes with thin wall cyst, and this hemorrhagic cyst will resolve in time. So the hemorrhagic cyst is nothing but the corpus luteum, which has blood inside. And if we do the scan on second or third day of the period, then if it is a corpus luteum, then it would have resolved by then. What about transrectal ultrasound? It has better resolution, better diagnostic accuracy, but the acceptance by the patient is not so very great. So we use transrectal ultrasound only in unmarried girls. So this is yesterday's scan which I have done. Here you can see this is one ovary on the left side. There is some cystic appearance. This is the uterus and this is the right ovary, which is showing the typical ground glass appearance. Again, this is the so this is the left ovary. This is the uterus, the left ovary again, and coming to the right ovary, you can see the ground glass appearance, which is the endometriotic cyst. So we sweep from the left to right or right to left, and we check the ovarian, the follicles, the size of the ovary, whether there is presence or absence of cysts. So Doppler is not much of a use. MRI again is not much of a use in endometriosis unless we are suspecting a deep infiltrating nodule into the rectum, where we want to prepare the patient, counsel her about shaving the nodule or bowel resection. Only in such cases, MRI is going to be helpful. So coming to the blood test like CA-125, it has low sensitivity, but it is helpful to predict recurrence. But in my practice, I have seen that the higher the CA-125, then the peritoneal involvement will be more. So the recurrence again will be high if the CA-125 levels are high. So 80% of patients with pelvic pain and raised CA-125 levels have endometriosis, while only 6% of those without endometriosis have raised CA-125 levels. So laparoscopy is again a gold standard to diagnose the extent and severity of disease. It should not be performed within 3 months of hormonal therapy to avoid underdiagnosis. Methodical approach is required. Thorough inspection of the lateral side walls, all ovarian surfaces, both sides of the broad ligament, bladder, bowel serosa, and inferior aspects of the cul-de-sac is needed. Uterine manipulation helps in visualizing the pouch of Douglas and rectovaginal septum. Photography and video recordings of the findings should be done ideally. This is very important in cases of infertile patients where the endometriosis clearance is done in one place and they come for IVF to another place, and we don't know the findings, what happened during the laparoscopy. So the photography or video recording gives us a lot of information as to how long we can wait. So this is a typical laparoscopic finding of the endometriosis, where you can see two egg kind of ovaries which are just sitting there in the posterior, stuck to the posterior wall of the uterus. So this is bilateral endometriomas. You can see that there is bubble adhesions in this, and this needs extensive clearance in terms of clearing the cysts in both the ovaries, and also clearing the adhesion. See here, these ovaries, I mean, they were not supposed to be here. They were supposed to be in the ovarian fossa, but because of the bilateral cysts, they have all come and gotten stuck to the posterior wall near the almost fundus of the uterus. So this woman had severe pain, and she has come for hysterectomy. And this is a repeat recurrence of endometriosis, which was cleared previously. So this is the rectal nodule, where you can see that the rectum is pulled up and it is attached to the posterior wall of the uterus. And using harmonic, we kind of release the bubble adhesions. And usually the bubble is stuck in the middle. So the red is where we are not supposed to cut. We need to make this pararectal space where the adhesions are flimsier, where we can get a yeah, this is where we'll have to go to prevent bowel injury. So this is very important because usually these kind of surgeries are operated by gynecologist along with the presence of a surgeon. So this is where your role is to understand how the adhesions happen in cases of endometriosis, and how to create the plane so that the chances of bowel injury will be minimal. So this case was done for a lady who came with severe pain, and there was a rectal nodule. So we had to do the shaving of the rectal nodule. So this is another case which was recurrence of endometriosis with previous surgery. This is the bladder which is opened while doing the adhesiolysis. The bladder was completely adherent to the anterior abdominal wall, and the bladder opened. We can see the Foley's bulb. So we just had to suture the bladder. And you can see this is a bulky uterus along with complete adhesion of the bowel to the posterior wall. You can see the endometriosis there. And we had to do the ureteric dissection and then do the hysterectomy after releasing the bowel adhesions. So this is endometriotic clearance which got infected, and you can see that there is pus coming out through that collected cyst. So this is infected endometrioma, and bowel is completely stuck to the endometriotic cyst. And this is a bulky uterus. So these are various cases, and we are seeing more and more of the redo cases where previously they are operated twice, thrice, and then they come for hysterectomy. So coming to the treatment of endometriosis, we have medical treatment and surgical treatment. So medical, we usually start with the painkillers like NSAIDs and COX-2 inhibitors, and then we go to combined dose pills. We give progestrogens, we give antiprogestins, GnRH agonists, aromatase inhibitors. And coming to surgical treatment, conservative surgery is recommended if they have infertility as their main symptom, and definitive surgery if they have completed their family. So NSAIDs, they are effective only in managing the pain. It has got nothing to do with the disease. suppression of ovarian function with either COC or medroxyprogesterone acetate, danazol, gestrinone, and GnRH agonists, all can be tried. And use of these for 6 months reduces the pain associated with endometriosis. So ACOG, initially they recommend 3 months trial of NSAID and cyclical ocipil. If the pain is still persisting, then to go for laparoscopy. If the patient is above 18 years and wish to avoid surgery, then we give GnRH agonists. If the pain resolves, then diagnosis of endometriosis is confirmed. Any low dose ocipil containing 30 to 35 milligrams of ethinyl estradiol used continuously to achieve amenorrhea can be effective in treatment of endometriosis. So this is one of the way that we can both diagnose and treat endometriosis when we are not sure of the diagnosis. So we give them 1 or 2 cycles of contraceptive low dose contraceptive pills, and if they are relieved of their symptom, then we make a diagnosis of endometriosis retrospectively. Cyclic OCP is used to provide prophylaxis against either the development or recurrence of endometriosis. NuvaRing can be used, but it is not available in India as of now. So these are various progesterone, and I think many of you would have seen like gynecologist prescription where they have loaded the lady with endometriosis with progesterone, with multiple varieties of progesterone. So dydrogesterone is the most recent with minimal side effects. So that is what we use 20 to 30 mg daily, but it is not very cost effective. And this doesn't take care of the disease per se. This is only for symptomatic management. So GnRH agonist, that is leuprolide 3.75 mg per month, maximum 3 doses can be given. So this can achieve a little volumetric reduction in the size of the endometriomas, but this again doesn't clear the disease. So when we have given 3 doses of leuprolide, we give add-back therapy with conjugated ethinyl estradiol, 0.625 mg with norethindrone plus 1200 milligram of calcium and vitamin D daily. So the goal of add-back therapy is it effectively to treat the endometriosis associated pain while preventing the vasomotor symptoms or bone loss. So treatment up to 2 years with COC add-back appears to be effective and safe in terms of pain relief and bone density. So this is an ideal situation for an adolescent endometriomas because they are not very keen on surgery, and also you don't want to do any surgery on them because of the risk of recurrence. So the number of surgeries that we do will reduce the AMH or the ovarian reserve proportionally. So we try to, the first surgery is usually the best surgery, and the surgery needs to be followed up with fertility treatment to get the woman conceived within 9 months of the surgery, so that the recurrence rate is reduced and the chances of fertility is higher during that time immediately after the clearance. So for adolescent girls who have severe pain with endometriosis, the ideal treatment is combined ocipils and, if needed, GnRH agonist 3 doses to keep the disease under control. So LNG-IUS, this is again uses the endometriosis associated pain. The insertion after laparoscopic surgery of endometriosis associated pain, it significant reduction in the risk of recurrence, moderate to severe dysmenorrhea at 1 year follow-up is seen. So this is ideal in case a woman who is symptomatic, who has finished her family, who has undergone the endometriotic clearance surgery, and who is looking to avoid the recurrence. So that is the time when you put in the LNG-IUS system, not as a first line. And again, here, if the woman is above 45 years of age, it is always better to go for hysterectomy than to retain the uterus and have a risk of the recurrence. If the woman is less than 45 and if she is not keen on hysterectomy, then LNG-IUS may be effective. But it is not useful in infertile patients and also in adolescent girls. So danazol, gestrinone, mifepristone, all of them can be used, but we don't use it routinely in our practice. Aromatase inhibitor, yes, I mean, we use letrozole, but then again, it is not a very practical thing to do. Some have also known to be used in endometriosis. So hormonal or anti-hormonal therapy has no beneficial effect on fertility, either alone or as an adjunct to surgery. Only surgical ablation or excision of the disease will restore fertility. And this has been my personal experience too, where the woman with endometrioma or with peritoneal endometriosis or with adenomyosis, with infertility, when they come and say that they don't want to undergo the surgery, they just want to go ahead with the treatment straight away, they want to go with the IVF straight away, they don't want to clear the endometriomas. I have not seen great results when they have done that. And once we have cleared it surgically and then gone ahead with the IVF or IUI, we have had better success rates. And this may be because that it improves the quality of the oocyte, and also it improves the endometrial milieu, which improves the rate of implantation. So ablation of endometriotic lesions plus adhesiolysis to improve the fertility in minimal to mild endometriosis is effective. The evidence is level A. The role of surgery in improving pregnancy rates for moderate to severe disease is uncertain, but we have found it to be useful. And there are no randomized control trials or meta-analysis to answer this question. So conservative surgery, an asymptomatic patient with incidental finding of endometriosis does not require any treatment, but we usually try to do the cyst aspiration at least. Excision or ablation reduces the pain. Excision rather than drainage or fulguration provides better pain relief, reduced recurrence, and histological diagnosis. But excision also reduces the ovarian reserve, where we are peeling the cyst wall from the ovarian cortex, which may again have follicles in the cyst wall, and it may reduce the AMH levels. So surgical excision always should be done with scissors, and we should try to avoid using any thermal instruments for the excision. So if the endometrioma is less than 4 centimeters, just aspiration, irrigation, and interior wall vaporized to destroy mucosal lining may be sufficient. When it is more than 4 centimeters, cystectomy is recommended. So again, following up after the surgery is equally important, where the woman should be offered various ART methods to conceive, either IUI or IVF, depending on the other parameters like uterine factor, her age, the male factor, all these things we should consider, and then offer her further treatment. So recurrent endometriosis is a nuisance, but it is a real problem in the present generation. So spontaneous resolution occurs in about 20% of endometriosis in stage 1 and 2. There could be residual disease, which can lead to persistence of symptoms or reappearance of symptoms within 3 months. Recurrence usually appears after 3 months. Incidence is about 6 to 30% in various studies, and it depends on age, stage of the disease, prior treatment, completeness of the surgery, extent of the peritoneal disease, and it usually presents as chronic pelvic pain and dysmenorrhea. So whenever an infertile patient or whenever a patient comes with the endometriosis diagnosis or endometrioma diagnosis, you should first take the woman as an entire thing and ask her what is her wish, like whether she would wish to conceive or she would wish not to conceive. See, if she doesn't wish to conceive, then it is very simple. You just go ahead, clear the endometriosis, put her on contraceptive pills or put her on LNG IUS, which will prevent the recurrence. But if she wishes to conceive, then the problem comes. So you should ask her whether she is willing to go ahead with further treatment, which may again cost her, like IVF or IUI. See, many patients, what they do is they will get their finances ready only till the endometrioma clearance, and they would have finished their savings there, and they don't go ahead with the further treatment. And once they have the money, they come back after 2 years, and we see that there is already a recurrence. So the uh, fertility treatment should always be followed up after the endometrioma clearance, and this has to be told to the patient. It should be documented that she has to undergo she may require fertility treatment in addition to the endometriosis clearance. So till she arranges her finances, better not to touch the endometriosis. Otherwise, there will be very high chance of recurrence, and her ovarian reserve will again go down. So again, it is the same thing. So for recurrent endometriosis, I personally think that hysterectomy with bilateral salpingo-oophorectomy should be offered, because if a woman has the tendency for recurrence, how many ever times you do the conservative surgery, clear the cyst or clear the adhesions, she will still come back till her menopause with the endometriosis problem, with the pain and with the chronic discomfort. So it is always better to offer hysterectomy with bilateral salpingo-oophorectomy if she is above 40, if she has recurrent endometriosis. So rectovaginal, rectal and uterosacral lesions always need surgery. This should be clearly engraved in everybody's mind, because rectovaginal endometriosis doesn't respond to medical treatment. So whatever medical treatment that we give, it only acts on the gland, and this only reduces the symptoms. It doesn't clear the disease. And the moment we stop the medications, everything will be back with vengeance. And endometriomas always need surgery. Even if you bathe the patient thrice a day with dydrogestrons or with multiple combinations of combined oral contraceptive pills, endometriomas will not get cleared. So only there may be a 1 centimeter reduction, but they will not get cleared. And abnormal anatomy and adhesions will always need surgery. So this alteration in the anatomy is again a very important factor for infertility, and this we should always remember. So when there is a TVS scan, and once we see that the ovary is not supposed to be in a place that it is, or it is not there in the place that it is supposed to be, then is the time when we have to think about the fertility enhancing surgeries, wherein we try to restore the anatomy by doing adhesiolysis and putting back the tubes and ovaries where they are supposed to be. So again, same ablation, Luna. So deep infiltrating endometriosis is now, I think, a lot of cases we are seeing of late, where we had to do bubble resections in some cases. So coming to another.
Ma'am, can I take some questions from the chat box?
Yeah, sure.
Please, yeah.
Yeah.
The first question from Ravi Shankar: is there an advance on the pathogenesis to understand the disease better?
See, these are all just theories, but none of it is still proven as to what could be the pathogenesis for the endometriosis. But what we see is like affluent classes. Yes, I mean, initially we were seeing a lot of endometriosis in affluent classes, but now in the past 2-3 years, we are seeing even all classes of people are affected with endometriosis, whether it is the lifestyle, whether it is the delay in the childbearing, whether it is the delay in the marriage, or whether it is the use of hormones. I mean, it's still like a big query as to what is the pathogenesis.
Yeah. Question on investigations like MRI and CT, but I think you have clarified that. This question was asked before that particular slide of yours came up. Just to summarize, you mentioned that it is for deep endometriosis and to study the status of endometriomas, the ovarian involvement, but that MRI has a limited role. Is that correct?
No, ideally the sequence of tests will go like this, sir. So first we evaluate clinically. And then the next test first we offer is the transvaginal scan, that is the 2D scan. And along with it, we do a CA-125 just to rule out peritoneal endometriosis, but that doesn't signify much. Then in case if in 2D scan, if we still are not very clear about the bowel involvement, then we advise for a 3D pelvic scan, which is almost equal to an MRI these days, because we have very good sonologists who give very good reports with the 3D pelvic scan. So the 3D pelvic scan will tell us whether the bowel is stuck, whether there is what size of a nodule is there in the rectum, and how much deep it is. All those information are gained with the 3D scan. If in a tier 2 cities, or if in a place where there is no facility for a 3D scan, no person to do a 3D scan, then definitely MRI will be better. Doing MRI also helps in kind of counseling the patient and involving the team. If you want to involve a gastrosurgeon, if you want to involve a surgeon who is well equipped to do a bowel resection, who is well equipped to manage the suturing if there is any bowel injury, and to help you out with ureteric dissection. So that is when the MRI will play a role.
All right. So will stopping treatment cause recurrence? When you
Yes,
decided on medical
definitely.
treatment, how long would you give it? Uh, or when would you decide to stop it?
See, the endometriosis, the disease will stay with her till she reaches menopause. So these are the women who have this kind of the endometriotic lesions elsewhere in the body apart from inside the endometrium. So they have this tendency, and this tendency will go on till they are menstruating. So the risk of having the endometriosis is till the menopause. Only after she reaches the menopause, she will get the relief. So if I am planning to give her treatment to prevent recurrence, then either I tell her to conceive, so that there is no periods for almost 1.5 to 2 years till she has a pregnancy and breastfeeding. During this time, because of the suppression of the hormones, the endometriotic lesions will be suppressed. So, if at all, if post pregnancy, if she doesn't want to have a child, then we put her on LNG-IUS, which works for 7 years. So till she is about 45, till then we try to follow her up.
All right. Okay. During LSCS, can we remove endometrial deposits and do an adhesivolysis?
Yeah, we can do, but I have tried it in a couple of patients, but they bleed too much, and have done cystectomy. I had to suture the ovary in a couple of cases, and there is so much of vascularity in the uterus and in the ovary, especially in a term pregnancy. So we'll have to have enough and good assistance to do it, but it can be done.
All right. But perhaps you wouldn't want to, because the lactation after your LSCS will keep the disease suppressed anyway. Would that be reasonable
Yeah,
to say
but
that?
till the collection of that endometrioma is there, sir, I mean,
Okay.
it will be there.
Okay.
So if it is just a opening of that cyst, and if it is just removing the adhesions, so that can be tried. But for that, we need to exteriorize the uterus.
Right.
So from the incision. So exteriorizing the uterus, and if there is any bowel injury, to manage that is a big challenge.
Yeah.
So you will have to decide based on case to case basis
Yeah.
whether you really want to do it at that time. See, because postpartum, the woman will need all the strength and all the energy that she can have to take care of the baby.
Yeah.
So if there is any problem, just because of your cyst, which is just going to be there without causing any much problem during the purpurium, would you really want to like interfere and do it?
Yeah. Yeah. That's a question. Difficulties encountered during hysterectomy in endometriosis.
the entire anatomy is altered. So wherever usually the endometriotic spots are in the posterior wall of the uterus, it is in the uterosacral ligament. So wherever those spots are, all the tissues will come and converge there. So we can see that there is everything will be medial to the center. So the ureter is pulled up, the intestines are pulled up, and everything is like, concentrating on that endometriotic activity. So we have to make sure that we are well versed with the retroperitoneal dissection. We have to do the ureteric dissection. We have to make sure that the ureter is safe. We have to know about our pararectal spaces, how to create the space, where to go. The plane identification is very important. How much pressure to put, what energy source we need to use, or when not to use the energy source when we are doing the adhesiolysis, especially with the sigmoid colon or the rectum. So those are the precautions that we should take, and proper help. So keep a surgeon standby in case if you need to suture. So all these things will have to be prepared.
Would you recommend bilateral ureteric stenting if you're
No, the stent makes the ureter very rigid, and not really. See, usually we dissect till the ureteric tunnel, and after that it is quite easy. And as long as we keep our instruments and the dissection close to the uterus, nothing much happens.
because you mentioned that the ureters are pulled medially,
Yes,
while
yes.
while while the a stented ureter may be stiffer, at least you will recognize a ureteric damage. Would that not help you?
Not really, sir. I mean,
No. Okay.
we can do it with even without stenting also.
Okay. You mentioned that a rectal nodule, and you mentioned a serosal clearance of the rectal nodule. We have come
Hmm.
across cases where the rectal nodule is transmural, and you have even seen it on the mucosal aspect of the rectum or a
Yeah.
rectosigmoid. But
Hmm.
clearing the outside, the serosal aspect of the nodule, would that be enough, do you think, or do you need
No, no,
rectal
no. That time bubble
resection?
resection needs to be done, sir.
Bowel resection needs to be done. Yeah,
Yeah,
just wanted
yeah.
to clear that. Okay, so would you then ask for a routine sigmoidoscopy to see if there is anything on the mucosal aspect of the rectum
If the
in
woman
bad
has bleeding
endometriosis?
PR,
Okay,
if the woman has bleeding PR, then
yeah,
only we ask for colonoscopy or sigmoidoscopy.
okay,
If the woman doesn't complain of it, then the transvaginal scan or an MRI will pick it up, the
okay,
nodule, how deep it is. If
okay.
it is reaching the mucosa, then we have to counsel and take the consent for bowel resection.
All right. Ravi, you have questions?
Yeah, excellent Dr. Shilpa so far. Basically, when you are looking at ovarian cysts, is there anything different you
Yes, sir.
do for an endometriotic cyst compared to a regular ovarian cyst? Because the plane of dissection is a lot easier when you are doing a regular ovarian cyst. Is it more difficult with the or do you have to sacrifice the ovary? Of course, in younger people you can't do that, but in patients who are who finish the family and things, is it better to remove the entire ovary with the cyst rather than just doing a ovarian cystectomy?
I will take this in two parts, sir. One is endometriosis is nothing like any other ovarian cyst. So this behaves very differently. And most of the endometriosis is in the reproductive age group women. So who are either seeking fertility or who are less than 40 and they are for conservative surgery. So doing hysterectomy or even oophorectomy now may not be in majority of the cases. But how it is different from the cystectomy, how it is different is here the cyst wall is very closely attached to all the ovarian follicles and the cortex. So when we are peeling off, so we have to make sure that we don't take too many follicles along our peeling off time. And also the major issue is like we can't use the thermal energy, like we can't use the energy source, which can again impair the blood flow to the ovary and it may reduce the ovarian reserve. So we just have to do it with the scissor, try to peel it off as much as possible, and only when required we use the bipolar. And if there is bleeding, we kind of put 1 or 2 stitches on the ovary, and we have to make sure that we don't touch the hilum, or the hilum should not bleed, because if it starts bleeding, then we try to coagulate more and more, and then it kind of reduces the blood supply to the ovary drastically. And many a times we see bilateral endometriomas where the problem comes. So in bilateral endometriomas, so if you want to choose oophorectomy, then we'll have to remove both the ovaries. So it is as good as doing a hysterectomy with bilateral oophorectomy and leaving the woman devoid of the hormones. And nowadays, patients, even if they are like 48, 49, they want to keep their ovaries. So because of the various things that they would have heard. So none of the women now are willing to get the ovaries removed. So I think last 3-4 patients I have done hysterectomy, they clearly want their ovaries to be conserved. So that is what the thing is now. So convincing the patient to get her ovaries removed is going to be a big challenge in the future.
Very nice. Dr. Shilpa, it's been an excellent class. Would you mind if we took up pelvic inflammatory disease in another class?
Yeah, sure, sir. Sure.
We will trouble you next month also, because
sure.
it's been really very useful and very, illuminating is the word I would like to use. So we will involve you next month, ma'am, for the pelvic inflammatory disease.
Yes, sir.
We have our staff here as well, senior surgeons. Niranjan, you have any questions or comments?
No, sir. No questions. It was an excellent talk, ma'am. Thank you.
Nuli, sir.
Madam, I have one question.
Yes, sir.
While doing
Sir,
hysterectomy,
one sec. Dr. Nuli is a very senior surgeon from Chikodi, and an inspiring personality, and a regular, attends classes very regularly, and we are very, very happy to have him in the group. Nuli, sir, yeah.
Madam, while doing this one hysterectomy, total hysterectomy and bilateral salpingo-oophorectomy for endometriosis especially. Hello?
Yeah, go on,
so,
sir.
So when we have too much difficulty in going ahead with the total, can we go ahead with the subtotal hysterectomy, madam?
Yes, sir. No problem at all. We can do the subtotal, but usually it doesn't come to that. See, whatever damage has to happen or the problems have to happen, it would have already happened. So if we have cut the ureter, we would have cut it before we reach the vault, or even before we reach that subtotal hysterectomy area also. We would have done all the damage possible. So if we are able to go till the cervix, then I think doing a total hysterectomy is quite easy. We don't expect much problems in that area. So the problem comes in the beginning itself, where when we are dissecting the infundibulopelvic ligament, or when we are just before the uterines are coagulated. So that is where the problem of the ureter coming in, and that is where the problem of this the bubble being stuck. So if we are able to release all this, then doing a total hysterectomy should not be a problem, sir. But yes, I mean, definitely subtotal hysterectomy is an option that we can consider if we don't want to go with, if we can't go ahead with total hysterectomy.
And during cesarean, madam, especially when already we know that the patient is suffering from endometriosis, do you encounter anytime the lower segment dissection, because we want to open the lower segment and deliver the baby? Did you had any dense adhesion with the bladder, and you were supposed to go to classical or something like that?
Usually endometriosis is only the posterior compartment, sir. Anterior compartment involvement is very, very rare. And we see the anterior compartment involvement after we have done the cesarean and the patient has come back with scar endometriosis. They have come back with bladder involvement and all that. So till we don't interfere by a cesarean, as a primary cesarean, we have never had any encounterment with the difficulty in lower segment opening or difficulty in baby extraction. This is not associated with endometriosis, sir. In PID, yes, but not in endometriosis.
In one of your video, there was opening of bladder, madam. Can you tell us why the bladder was opened? And
No, that was previous. It was adenomyomectomy was done in that case, sir, and the bladder was completely pulled up, and it was adherent to the anterior abdominal wall. And while we were releasing the anterior abdominal wall adhesion, so we opened the bladder.
Yeah, myomectomy is particularly known for dense adhesions post-operatively.
yes, sir.
Yeah.
Yes, sir.
Yeah, yeah. Any questions from students? All
No,
right.
sir.
Okay, all right. Dr. Shilpa, thank you very much for an excellent lecture. We really appreciate your sparing your time for it, and we will get in touch with you for a class in March, or perhaps if we miss March, April, on pelvic inflammatory disease.
Sure,
Thank you.
sure.
Thank you very much to all the participants, and good night.
Thank you, sir.
Thank you.
Thank you.
Good
Thank
night.
you. Thank
Thank
you,
you.
everyone.